there, my name is Crystal Walker. I am a physician assistant with a Doctor of Medical Sciences, and I am the Director of Clinical Services in the Substance Use Department of My Health, My Resources, Tarrant County. So today I want to talk about how I approach mentoring. So first of all, to me, mentoring is more than just an education. It is an intimate relationship between two people where one is providing a supportive form of development, where the mentor will provide encouragement, motivation, direction, advice, and will also share knowledge and resources to the mentee. And this really should be led and motivated by the mentee and what their needs are. Now, there are two approaches to this. There's a formal approach, which is very structured, has goals, timelines, metrics, and sometimes comes with a stipend or an award. And then there's the informal approach, which is semi-structured and is more of a lasting relationship and most often is completely voluntary. Now, traditionally, you think about mentoring in that one-on-one aspect where you are together, two people providing this direction. But I really want you to expand your thought on that, where you could have group mentorships where there are multiple mentees that are addressing a particular topic or issue. It could be situation, very pinpoint, where you are trying to resolve an issue with a specific topic or regarding a specific skill or project. And this can be more spontaneous or a more urgent need. And then there is your panel or forums, which is a little on the other side of the coin of a group setting where you actually have multiple mentors in this alternative, where you can get alternative perspectives, clarifications on specific topics. Now, breaking that down even further, each one of those approaches, you can think outside the box, outside of that in-person, one-on-one, Mr. Miyagi type of approach of in-person, and start incorporating virtual aspects where you're not just meeting in an office or a classroom or a coffee shop, but you can do audio-visual platforms, Zoom, Teams. You can pick up your cell phone. You can use email, text messages, or even digital spaces such as online forums. We can also take two different approaches. And this is really where our digital space comes into a great benefit, where you can not only have your synchronous approaches, that real-time, in-person, one-on-one approach, but also asynchronous approaches, such as using text messages or emails, or even have pre-recorded lectures or pre-recorded directions. And you can use newsletters or those digital spaces like forums to really provide a well-rounded benefit to the mentor and the mentee. Here are a couple of great options that I like to utilize in my field of medicine, which is addiction medicine. One great resource is pcssnow.org, where they have three options: a discussion forum, an ask a clinical question, and one-on-one mentoring, where you can actually be assigned a direct mentor or use the panel of experts that are online in the ask a clinical question or the discussion forum. You could also join a formal society like ASAM or ASAP, which has member directories that you can get in contact with an expert in this field, or attend quarterly medical directors meetings such as roundtables and things of that nature. There's also a great resource at Project Echo. One that I'm a part of is the TexRx Echo, and this revolves around substance use and addiction medicine, and this is provided by CSTAT and Be Well Texas. Thank you.
Hello, thank you for allowing me to talk about mobile clinics and mobile care. I'm Dr. Raul Ayala. I want to talk to you today about mobile clinics and how we incorporated them into our residency programs, and primarily in family and community medicine. We are located in Central California. We are delivering care to the most vulnerable communities in Central California. There's about 1.6 million people that live in Fresno, Kings, Tulare counties. And one important point here of demographic is that our Medicaid ranges from 31 to 44%, with the average in California being 29%. And 10% of the people that we see are uninsured. Another important point there is that 20% of people in these areas live in poverty. We have been incorporating these programs for the last 4 years. It's really started with how do we address some of the inequities of our communities, and addressing things like transportation insecurity, access to care, housing insecurity, education, and of course, poverty. I think a lot of this work has been in progress, but we're really happy that we're now got 2 mobile units, one going north, one going south, and the team care of our residents and our faculty, as well as our volunteer doctors, have been incorporated into this. We wanted to make sure that, we were incorporating the 6 core competencies that ACGME brings. Why? Because we know that our residents, as they're learning, as they're experiencing, we need to make sure that, we're using competency-based medical education, but also addressing some of the areas of professionalism, interpersonal community skills, and also systems-based practice, because we know that if we address the patient as a whole, we can incorporate the best practices for that particular population and utilizing the tools that are available to us to best care for those patients. A lot of the areas that we started with were, again, addressing our big agricultural community where we have patients that are uninsured. We do have areas of Central California that are still homeless, and addressing things like refugee and migrant camps where we can allow and take the best of what we have in our community clinics into these mobile units and going to where the care that needs to be provided. Some of the care that we provide through our mobile care is looking at just the basics of primary care with same-day visits. We're also partnering with our schools, our nonprofit organizations, providing physicals, sports physicals, but it's also medical management around diabetes, hypertension, hyperlipidemia, asthma, immunizations, and all through our point-of-care testing. Our mobile units are equipped with point-of-care testing and screening tools that will allow us to take care of patients in this fashion. And the other thing that we needed to do as we incorporated this into our community medicine was looking at clinical algorithms to allow us to have the best practice in a team-based approach. And so as you can see here in front of you, we started to really address some of the most common things that we were addressing within our clinics, within our communities, and that was medical management. It was around wound care. It was around questions of medications, or even just wellness with vaccines. So a lot of this has allowed us to partner with our community members, our community nonprofits, where we have incorporated food insecurity programs and also transportation. Because what this is allowing us to do is incorporate us into the rest of the healthcare system, where we can ask patients, we can address the chronic conditions that they may have, but also that we're addressing their social needs. And so we're able to transition them into our clinics, into our hospitals, and into the programs that allow them to have the best care that they can. Now, this program is a work in progress. We're really proud of this work here. If you're interested in mobile care, this was one way that you can incorporate that. And I'm really happy to have presented this to you today. Thank you.
Mobile apps are useful for both providers and patients. Providers can reference apps quickly when caring for their patients, whether it's for a treatment plan, drug interactions, or general information. And patients can benefit by having more knowledge when talking to their providers. When creating an app, it's important to work with an experienced educational app developer. Working with them to determine the functionality and features of the app up front helps to minimize delays. Once functionality is determined, the next step is to create a storyboard and write out the specific content. If the app is for patients, it is important to check the literacy level of the content, keeping it at about a 5th grade level. Also, include patients and community members in the development of the app. Once the app is built, having multiple people test the app, especially those not involved with developing the content, is important to get objective feedback. Depending on how in-depth you want to get, there are validated surveys that can be used when reviewing and testing the app to help rate the content, functionality, and aesthetics. After testing, a brief description of the app and approval from Apple and Google is needed before the app is available for public access. The last step once the app is live is promotion, and that can be through various avenues and could include a launch event with partnering organizations. Raudel and I will be featuring 3 apps that we have worked on. The first app is for the Rural Telementoring Training Center, and it is designed as a resource for partners to use when developing, implementing, and evaluating their telementoring program. It features descriptions and definitions of the different telementoring models, walks them through the TTA pathway to implement a model, and has a toolkit for implementation teams to use to evaluate their model. We are able to capture data when people download the app, but also when they fill out their TTA steps and the toolkit. This app is available in the App Store and Google Play. Now I'll turn it over to Raudel to talk about the Help app.
Thank you, Trisha. Our HIV/HCV Educational Learning for Providers, or HELP app, was developed as an aid for providers needing guidance on managing and treating HIV and HCV co-infection. The app was developed with input from both specialty and primary care providers and guidance on how to manage and treat HIV/HCV co-infection cases out throughout the care cascade, from initial screening and diagnosis through choosing treatment options, how to stage the disease, and hopefully achieving an HCV cure for that provider's patient. The app features the decision tree to help providers choose the best treatment options for their patients, a drug access protocol to help them get approval for the treatment best for their patients, and offers continuing education resources as well. This app is available on the Apple and Google Play Store for anyone to download. Our HIV/HCV patient education app was also created to educate newly diagnosed HCV and HIV/HCV co-infected patients. The app was developed using community focus groups, and community health worker input was heavily involved in this, and is designed to either be delivered by an MA, LVN, CHW, or by the patients to do it their own. The app uses basic terminology and is set at a 5th grade reading level. The app walks newly diagnosed patients through the understanding of their diagnosis, ways to prevent transmission, reduce stigma, and ultimately offers hope for treatment, because there is treatment and there is an HCV cure as well. To make sure patients are grasping the information being presented, a set of teach-back questions appear to test their knowledge as they go through the app. The app is available in both English and Spanish, and there's both a mono-infection HCV version and a co-infection HIV/HCV version that can be downloaded in the Apple and Google Play Store. Thank you.
Hi, everyone. My name is Sydney Grant. I am the co-host of our podcast, Rural Health Leadership Radio, and I'm excited to welcome you to this short presentation on bridging the rural connection gap. So for some background on this podcast, my colleague and co-host, Dr. Bill Oxier, created Rural Health Leadership Radio as a free, simple way to connect people from all across rural healthcare. So each week we have a new guest that comes on to share their story, best practices, lessons learned, resources, and much, much more, all specific to rural healthcare. And these are guests from all across the spectrum of rural healthcare, industry, academia, administration, research, and everything in between. But again, all rural specific. So the mission here at Rural Health Leadership Radio is to improve the world by engaging rural health leaders in conversations, learning, and research. And we have been on the air now for 7 years. I joined as an intern back in 2018 and have come microphone side and joined as a co-host this past year. To get a little bit deeper into the why of our podcast and what we do, we know that rural healthcare faces a lot of issues and obstacles. Particularly, the closure of rural hospitals was what inspired Bill to create this podcast to share best practices and resources that might help keep other rural facilities open. So he reached out to some rural hospital CEOs from all across Florida. We're both Florida-based, and was asking about the issues they were facing. And he was inspired when one CEO told him that he felt like administrators kept secrets. You know, there was no way of sharing what did or didn't work for people. And he wished there was a free, simple way to share best practices and knowledge in rural healthcare. So with that in mind, we thought this podcast would be a great way to be the tide that raises all ships, so to speak, by sharing these stories, resources, and knowledge that may have worked for one person so that others can learn from it and in turn overcome some of that isolation that we see so often in rural. So like I just mentioned on that previous slide, isolation, we know in rural America, there can be a huge sense of this isolation, not just geographically, but emotionally too. And so that was something we also wanted to overcome with this podcast, was the great disconnection, as Bill and I call it. So we know inherently no one wants to be separated from the herd. Everybody wants to feel included and like they're a part of a community, but that can be difficult when you're physically distant from people. So we know there are also negative impacts that come along with that isolation and disconnected feeling. And so through our podcast, not only are we able to share these resources and key pieces of information that can help people, but we also create a community for those rural healthcare professionals, really anybody living in rural America to connect. So a great opportunity to not just provide knowledge and resources that can be a huge benefit that people may have not known were available otherwise, but also providing an opportunity for connection on a deeper level. And so by creating this wonderful community of like-minded individuals, we're able to connect ideas and people that may have never been connected otherwise. And it's been incredible to see how the experiences and stories shared through this podcast can make such a difference. So as we grow, there's more to offer. The more our community grows, the more information and resources and knowledge there is to share to improve healthcare in rural America. So here at Rural Health Leadership Radio, we will continue to share the information and stories that can help those in rural healthcare. We'll keep working to reduce isolation by providing this community and continuing to showcase the value and diversity that exists so strongly in rural America.